Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Zaid. Today I'll be speaking about primary defects of antibody production. I divided it into parts, so I'll begin with part 1. So our objectives are to know basic information about these three diseases: X-linked Agammaglobulinemia, common variable immune deficiency, selective IgA deficiency. So let's start. Of all the primary immune deficiency diseases, those affecting antibody production are most frequent. Patients with antibody deficiency are usually recognized because they have recurrent infections with encapsulated bacteria predominantly in the upper and lower respiratory tracts. For this information that out of all primary immune deficiency diseases, the most common is the antibody affecting the antibody production. This information is important because it's related to one of the questions at the end of the video. Okay. Now I will start with the X-linked Agammaglobulinemia. The other name is proton Agammaglobulinemia. It has a profound defect in B lymphocyte development, resulting in severe hypogammaglobulinemia plus absence of circulating B cells. This is very important information because it differentiates it from other diseases. Plus small to absent tonsils and no palpable lymph nodes. The carriers for this condition are detected by doing the mutation analysis. Prenatal diagnosis of male fetuses is possible if mutation is known in the family. Clinical manifestations: most boys affected with this condition remain well during the first 6 to 9 months of life. Why? Because they received the IgG antibodies from their mother, right, during pregnancy. Thereafter, they acquire infections with extracellular biogenic organisms such as Streptococcus pneumoniae and Haemophilus influenza, unless they are given prophylactic antibiotics or immunoglobulin therapy. Okay. Some patients who had the condition and received live polio vaccine, they had paralysis. So remember this information. Diagnosis: clinical, plus doing immunoglobulins, the IgG, IgA, IgM, and IgE. It is far below the 95% confidence limits for appropriate age and race matched controls. There is like few information I want to mention how to differentiate this condition with the other conditions like the transient hypogammaglobulinemia of infancy. In this condition, levels of natural antibodies to type A and B red blood cell polysaccharide antigens, which we are calling isohemagglutinin, and antibodies to antigens given during routine immunizations are abnormally low in this disorder, whereas they are normal in this condition, transient hypogammaglobulinemia of infancy. The other thing, we can do flow cytometry. Why? Because it is important test to demonstrate the absence of B cells, which will distinguish this disorder from the common variable immune deficiency, the hyper IgM syndrome, the transient hypogammaglobulinemia of infancy. So to diagnose, it is the flow cytometry. Okay? Now moving to the next disease, the common variable immune deficiency. It has been called acquired hypogammaglobulinemia because of generally later age of onset of infections. It will not start from early. A syndrome characterized by hypogammaglobulinemia with phenotypically normal B cells. So the B cells are here. Okay, likely consist of several different genetic defects with autosomal recessive or autosomal dominant inheritance. Patients with this condition have autoantibody formation and normal-sized or enlarged tonsils and lymph nodes. Almost like 25% of patients have splenomegaly. Sepsis and meningitis with encapsulated bacteria occur more frequently than the general population. So these are the information about that. Moving to the selective IgA deficiency. It is the most common, well-defined immune deficiency disorder. It has also phenotypically normal blood B cells are present. Okay. Intestinal giardiasis is common in this condition, and really it came in questions, so remember that. Children with IgA deficiency vaccinated intranasally with killed poliovirus produce local IgM and IgG antibodies. Now, can we transfuse blood to these patients? Not as usual. It should be either washed, the blood from the donor, either it should be 5 times washed in 200 ml volumes normal donor erythrocytes, or the donor is IgE deficient. In these conditions, we can transfuse this blood to the IgE deficient patient. Why? Because selective IgA deficiency, in 44% of the patients, there is antibodies to the IgA. Okay, so that's why we cannot transfuse any blood to these patients. Administration of IVIG, which contains more than 99% of its IgG, is not indicated. Okay, because most IgA deficient patients make IgA antibodies normally. Okay, so it is not indicated. Now I finished this video. I will move, the part 2 will be next. Okay, I'll be doing some questions related to the video of today. Okay, starting from, which of the following types of immune deficiency is suggestive when a child develops paralysis after vaccination with live attenuated poliovirus? I answered this one in my lecture. The answer is B, cell defect. So next is a 1-year-old boy develops recurrent pneumonias and otitis media. Examination reveals absence of tonsils and no palpable lymph nodes. Lab tests reveal very low level, less than 2 standard deviations below the age-appropriate level of IgG, IgM, IgA, and IgE. Peripheral blood flow cytometry demonstrates absence of circulating B cells. Of the following, the most likely diagnosis is? So the answer is D, proton Agammaglobulinemia. Yani we should know it once we know that there is absence of tonsils. Flow cytometry is an important test to demonstrate the absence of circulating B cells, which will distinguish X-linked agammaglobulinemia from most types of common variable immune deficiency, the hyper IgM syndrome, and transient hypogammaglobulinemia of infancy. Next, a 4-year-old boy has recurrent attacks of gastroenteritis caused by Giardia lamblia. Which of the following diseases should be suspected in this boy? So the answer is selective IgA deficiency. Patients may be asymptomatic or may develop cyanopulmonary or gastrointestinal infections, especially Giardia. 7-year-old child with selective IgA deficiency develops car accident requiring blood transfusion. The type of a blood transfusion reaction that is most likely encountered in this child is. The correct answer is D. Acute anaphylactic reaction. Serum antibodies to IgA are reported in as many as 44% of patients with selective IgA deficiency. These antibodies can cause non-hemolytic transfusion reactions. Washed erythrocytes or blood products from other IgA deficient individuals should be administered to patients with IgA deficiency. Next, absence of tonsils suggests, of course, the answer is B, agammaglobulinemia. Absence of tonsils suggests agammaglobulinemia or SCID, severe combined immune deficiency. Whereas increased size of lymphoid tissue suggests common variable immune deficiency, chronic granulomatous disease, autosomal recessive hyper IgM syndrome, or a human immune deficiency virus infection. A 3-year-old male presented with recurrent attacks of meningitis, pneumonia, and diarrhea due to giardiasis. Started from second half of first year. The most likely diagnosis is, of course, B, agammaglobulinemia. Patients with agammaglobulinemia usually present during the first 6 to 12 months of life. Although some patients present with symptoms of 3 to 5 years of age, these patients develop infections with Streptococcus pneumoniae, Haemophilus influenza type B, Staphylococcus aureus, and Pseudomonas, organisms for which antibody is an important opsonin. They also have increased susceptibility to giardiasis and enteroviral infections, leading to chronic enteroviral meningoencephalitis and vaccine-associated poliomyelitis. Okay. Next, the following are true regarding common variable immune deficiency except onset usually in the second to third decade, serum IgG levels are usually less than 300 mg per deciliter, IgA levels less than 10 mg per deciliter, patients exhibit small tonsils and lymphoid hypoplasia, patients may have splenomegaly. Of course, the answer is D. Patients exhibit normal-sized or enlarged tonsils and lymph nodes. Next, 5-year-old female presented with chronic diarrhea, abdominal distension, weight loss, recurrent cyanopulmonary infection. The most likely diagnosis is, of course, it is C, IgA deficiency. Many patients with selective IgA deficiency are asymptomatic. In others, it is associated with recurrent cyanopulmonary infection, IgG2 subclass deficiency, specific antibody deficiency, food allergy, autoimmune disease, or celiac disease. IgA deficiency occurs in families suggesting autosomal inheritance. It also is seen in families with common variable immune deficiency. Next, immunoglobulin replacement therapy is indicated for patients with the following except, of course, the answer is E. Absent IgA, allergic reactions to IVIG can occur in patients with absent IgA. A 2-year-old girl with frequent attacks of upper respiratory tract infections since the age of 6 months. She is thriving well and has no other illnesses. Clinical examination is unremarkable. Apart from cervical lymphadenopathy she has, her serum immunoglobulin level was low. What would be the most likely diagnosis for this girl? The answer is D. Transient hypogammaglobulinemia of infancy. A 12-year-old boy has a history of recurrent pneumonia for the last couple of years, before which he was apparently normal. Chest X-ray revealed bronchiectasis. WBC is normal, hemoglobin is low, platelets are low, retics are high, serum immunoglobulin level very low, autoantibodies are positive. What would the most likely diagnosis? What it would be? The answer is D, common variable immune deficiency. Next, 9-month-old boy presented with recurrent attacks of diarrhea, thrush, failure to thrive shortly after birth. You suspect immune deficiency. Of the following, the most common cause of this condition. On purpose, I brought this question in this video because I mentioned to you that the most common immune deficiency is related to the antibody defect. Here is the answer is C, deficiencies in T cell function. Children with defects in antibody. Why? Sorry, before reading the answer, because here in the question they specified it not in general. They specified it as shortly after birth. That's why here the answer is deficiencies in T cell function. Okay? Children with defects in antibody production, phagocytic cells, or complement proteins have recurrent infections with encapsulated bacteria and may grow and develop normally despite their recurring infections, unless they develop bronchiectasis from repeated lower respiratory tract bacterial infections or persistent enteroviral infections of the central nervous system. By contrast, patients with deficiencies in T cell function usually develop opportunistic infections or serious illnesses from common viral agents early in life, and they fail to thrive. Next, 3-year-old boy presented with recurrent attacks of pneumonia and otitis media since first birthday. Your diagnosis is X-linked Agammaglobulinemia. Of the following, the most likely offending organism is E, Streptococcus pneumoniae. They acquire infections with extracellular biogenic organisms such as Streptococcus pneumoniae and Haemophilus influenza, unless they are given prophylactic antibiotics or immunoglobulin therapy. Next, 5-year-old boy presented with a history of recurrent attack of secretory otitis media and purulent nasal discharge, Haemophilus influenza revealed by culture of ear discharge. On physical examination, there is no tonsillar tissue and no palpable lymph nodes. Of the following, the most appropriate test to confirm the diagnosis is measurement of course, the answer is flow cytometry. A. The diagnosis of X-linked Agammaglobulinemia should be suspected if lymphoid hypoplasia is found on physical examination, minimal or no tonsillar tissue, and no palpable lymph nodes. Flow cytometry is an important test to demonstrate the absence of circulating B cells, which will distinguish this disorder from common variable immune deficiency, the hyper IgM syndrome, and the transient hypogammaglobulinemia of infancy. Next, a 3-year-old girl presented with recurrent attacks of chest infection and frequent episodes of chronic diarrhea. Stool examination revealed Giardia lamblia and serum IgA level was very low. The question is, regarding this condition, all the following are true except autosomal dominant inheritance. Yes, we said it's possible. Phenotypically normal B cells. Yes. Administration of IVIG is not indicated. Yes. Environmental factors may trigger the disease. We'll see the next. It is associated with a celiac-like syndrome with a dramatic response to gluten-free diet. The answer here is E. An isolated absence or near absence of serum and secretory IgA is the most common well-defined immune deficiency disorder. IgA deficiency is associated with a celiac-like syndrome, which may or may not respond to a gluten-free diet. That's why we should also do the total IgA when we are screening for celiac disease. So now I have finished my video. I hope it benefited you. These are my references. Thank you very much.